achieve somewhat universal health coverage, there's a commonality that we need to learn. Those budget transfers vis-a-vis public financing has been done through the National Health Insurance Entity. What is the difference with our countries? We are running parallel systems. Significant budget transfer of public financing is still going through the ministries of health. And it's not a bad thing. But you need to make up your mind. Do you want to use that insurance pathway as a purchaser, or you want to use the Ministry of Health pathway as a purchaser? And I'm not going to take a position. In fact, let me tell you, for countries that have achieved universal health coverage on our continent, some of them don't have health insurance organizations. So, it means that you have to make a policy commitment. If I want to use this, then I'm not going to double dip. So several of our countries, including Nigeria, a lot of monies are still transferred to hospitals through Ministry of Health, and there's just simply passive purchasing going on there. The third thing is this. What I've heard all 3 years today is probably mostly, yes, we have these entities contracting with us as private sector, but there are other things too. We can begin to look at output purchasing. Must we buy dialysis machines? Can we not buy dialysis sessions? Can the insurance entity not say, you know what? I want to buy 1 million radiotherapy sessions. And I put the money with my health insurance entity, or even your Ministry of Health, to buy the outputs. So, ladies and gentlemen, that's just my own perspective, and we would explore some of this from the government side to what the private platforms are doing, to significant examples either at a subnational level or at a sub-sectoral level across the subcontinent. So may I call on my panelists? Mr. Tule, the Honorable Mr. Tule from Liberia. The world-famous Mrs. Claire Mashai. She needs no introduction. From Benin, Dr. Lucian. Is he here? Yeah, Dr. Lucian, yeah. Good. From Nigeria, we have Dr. Uche. Great. Please, a round of applause for him. And my friend, Dr. Ben Kechika from Nigeria as well. As I said, it's not going to be a long one. We're going to go straight to the point, but we're going to go in a systematic manner. And I'm going to start from Liberia. So there's a need for countries to say, this is my UHC commitment. This is my strategy. And within that strategy, this is where the private sector fits in. This is where I'm going to cover the poor and vulnerable. This is how I'm going to deliver my services. Could you kindly just share with us, that Liberian common universal health coverage policy commitment? Mr. Minister, sir. That's fine.
Good morning to everybody. So, before going to the point, I'd like to raise a couple of issues, and permit me, Mr. Moderator, because it serves and justifies the reason why we should have a dialogue. Dialogues are meant to strengthen relationship. In this case, it's between the private sector on the one hand and the public sector, comprising of the larger consumers headed by the government. From what I've heard from yesterday to today, the private sector has deliberately omitted key component of the definition of UAC, and that in itself raises more suspicion than wanting to solve a problem. And I want you to challenge me. Go to WHO definition of UAC. It puts treatment or medication at the last. There are three elements of UAC. In the context of accessibility, there is the promotional aspect, health promotion, and there is the preventable aspect, and then before the treatment component comes in. All that I have heard from yesterday till now is about treatment, 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 treatment. Now, if you said that or presented UAC to gravitate only around treatment, and an educated person, a public health specialist, medical and professional persons discover that UAC is beyond that, there is a natural mistrust. And you need to be clear about that. So the private sector needs to know that you have much more a larger space beyond treatment. I listened to the fellow from Nigeria yesterday. I think it's a publisher. And he tried to make the point, even though he misses the point of health and medication. Medication is personal and confidential, whereas health is meant for public debate. So the private sector could do even much more better in the first two elements of promotion and prevention. So let me come back to Liberia scenario, which I'm actually here to share with you as a country. So Liberia, and it's a small country, probably with very little population of just approximately 5 million people. Our strength, we've been able to overcome two key outbreaks, Ebola and that of COVID-19, making a very high, excellent passage. We have built our universal health care coverage, the strength of it in the community. Community health, community engagement, community collaboration is much more easier and less difficult and more convincing as well as assuring as compared to any form of financial modality that may be proposed. Because in that way, it is the community who devises the strategy that is much more workable to us or to a said community. And all of the other speakers who have said in previous time have outlined one key point. That is, it is not a one-size-fits-all. So if you have this concept, you will realize that maybe what I'm saying is not applicable to your environment. But in our own environment, again, as a small country with a small population, we relate to one another much more. But I think also collaboration with the private sector is very, very, very crucial. Howbeit, the private sector could go beyond just the idea of medication or treatment, and then taking advantage of the other two elements of promotion and prevention. Thank you.
Thank you very much, Honorable Minister. Hopefully, we'll still have some time to hear from you, but I like your perspective in terms of emphasizing prevention, especially for us on the continent. We don't have that fiscal space prevention, as they say, is better than cure. Madam Chair, Forbes, I've heard you say repeatedly over and over since yesterday. So, private health sector is at the table? Is private health sector at the table now?
Absolutely, I think so.
If so, how? Why?
So thank you very much, Olumide. Let's look at our region, West Africa. The first thing is that healthcare in our region is provided by both public and private sector. By a study that was done by the Health in Africa World Bank several years ago, the study showed that between 50 to 60%, up to 60% of healthcare is provided by the private sector. But as you heard the minister say yesterday, the challenge has been over the years that healthcare by the private sector is very fragmented. And a lot of that private sector is in the informal private sector. So it includes people walking into patent medicine stores, into churches for medication, and so on and so forth. So one of the challenges government has had in trying to engage this private sector is that we're all over the place and not really in one place. So one of the things we've done with the work and help of the World Bank and several other institutions, including the East African Healthcare Federation, was to show the importance of having federations at the various countries. And that has led to, now we have 9 federations across West Africa. And I don't need to mention them all. Everybody's sitting in this room and the leadership is in this room. And with this, we have, at the country level, people being able to speak with one voice for the whole of private sector. And when we talk about private sector, it's an entire ecosystem. So it's services, people who are providing the services, people who are doing health promotion, people, captains of industry who are making the pharmaceutical products and the consumables, people in logistics doing the supply chain and getting to the last mile, people who are experts in vaccine and cold chain management, all the way up to those who finance healthcare and those who do capacity building. We've also expanded this to include NGOs that are in this space that help us to do institutional strengthening and capacity building in this space. And now we're very proud that we have these various federations across the various countries. And as an umbrella body, FOAPS, or the West African Private Healthcare Federation, is in a position to unify the voice of the private sector to speak with government and be able to interact and influence policies. Now, prior to this, we were dictated to, and there was a lack of trust. As the Honorable Minister said today, we're lucky we're hearing this firsthand. And things have changed over the last 2 decades. And really, you said it at the beginning. Usually, public sector has their meetings and we're told afterwards, this is the new policy and we have to follow. But right now, many governments across Africa, especially West Africa, have recognized that you are the Minister of Health, not the Minister of Public Health, and therefore you must bring in the private sector. The people who are slower to act, actually, forgive me, are some of the donor partners. Some of the donor partners have always gone straight to the government to do implementation, and they've seen that they've had challenges on the implementation side. So there are synergies of both sides. There are pros and cons. Why don't we use the strengths of both the public and the private? Because we need to be able to change and get universal healthcare coverage and get access to quality healthcare that is affordable, that is effective. We need to be able to work together. Why don't we leverage on the strengths? And that's what the healthcare federations of the various countries, the associations, the alliances are able to do. The government now has one force to be able to speak with when they want to do their strategic plans, 5-year, 10-year, 25-year strategic plans, that we're in the room while these policies are being done. The private sector voices are being heard, and we can influence them. When we're talking about access to finance, we're talking about money, we're talking about promotion, we're talking about prevention. And really, it shouldn't really be about sick care. It must be about well care. And you have, through the efficiencies of the private sector, not said by us, but the known facts. We have competencies when it comes to data management, when it comes to economies of scale, when it comes to purchases. But there are challenges with that unity. And a couple of things that must be done for us to realize is that there's no one-stop fits all. There's no one fits all for each country, neither is there for each region. We also have to recognize that competency must be built on both sides. So we heard in the panel this morning that the department in the Ministry of Health of Cote d'Ivoire has a dedicated department for dealing with the private sector. That is one of the things that is important. So we must be able to build capacity within the public sector on how to engage the private sector. The private sector must organize themselves in a way through the federations to speak with one voice, not the president speaking and saying everything, but having constant meetings and dialogue as private sector, coming up with a wish list of things that we want and engaging government in a structured dialogue. Now, if we talk about
So,
today's
Claire,
conference,
yeah,
just one second, Malumde.
Okay,
if we
if
talk
you want
about
to...
today's conference, it is about that public-private dialogue. I would like to change that slightly. It must be structured public-private dialogue. So it's not just to come to the conference today and talk about these things, but what is the engagement when we get back home to our various institutions? Do we have a ministerial meeting? Do we have a structured meeting every quarter or half a year or whatever it is to engage government? Do they invite you for their planning, and what are the ways forward?
Thank you very much. Food for thought for you. If we have time, just hold this. So, should the private sector go through a rigorous accreditation and empowerment program whilst the public sector is left on its own? Do you think they should be subjected to the same standards? Is that not why we set up these entities called Health Insurance Authority? So that everyone meets a particular quality standard. But we'll come back to you. Dr. Lucien, Benin has perhaps one of the youngest, and there's an intense policy dialogue going on now in terms of setting up health insurance or contracting mechanisms with the private sector. We've heard from the minister the kind of processes that goes through having a policy commitment. We've heard Claire tell us the roles of private sector. If you can just give us some concrete examples of how you are able to engage in real life, in the ongoing conversations, so that we can maybe take a thing or two from your experience, from your lived experience.
Oui, merci à vous. Effectivement, le Bénin est jeune avec une expérience riche, mais aussi de nombreux défis encore à dépasser. Il y a quelques années, il était reproché au secteur privé d'être trop fragmenté et qu'il soit impossible de parler avec une multitude d'interlocuteurs et qu'il y avait nécessité à se regrouper et à former une seule entité pour parler en face à face avec le gouvernement. Ce qui a été fait en 2013 par la mise en place de la plateforme du secteur sanitaire privé, accompagnée dans ce travail-là par l'USAID. Et cette structure a été mise en place, mais elle a besoin de grandir, elle a besoin de devenir forte. Parce que quand on parle de dialogue, il ne s'agit pas de se mettre en situation d'être le petit-fils qui parle avec son grand-père. Il faut qu'il y ait le même niveau de compréhension des défis du pays en matière de santé. Parce que ces défis concernent aussi bien le secteur privé que le secteur public. Et quand on va à la table des négociations, il faut que le secteur privé ne se contente pas seulement de faire la liste de ces défis, la liste des revendications, mais être capable de discuter des défis de la nation. Et c'est en cela qu'il peut être un partenaire véritable. Et c'est cet apprentissage-là qui est important, que dans toutes les plateformes, chacun des acteurs puisse faire, pour être capable, non pas seulement d'aller dire « nous voici ce qu'on veut », mais de partir des défis que le pays a, et à partir de ces défis, voir quelle est la part qui peut être assurée par le secteur privé, et à ce moment-là, décliner l'offre de services. Et à ce moment-là, on va négocier les modalités de mise en place de la mise en œuvre des solutions par le secteur privé. Au Bénin, on a admis que le patient reste au centre des préoccupations et que dans le cadre de la CSU, nous devons faire en sorte que partout où le patient va chercher des services de santé, que ce soit au public ou au privé, qu'il rencontre des soins de qualité. Ce qui fait que dans l'évaluation de la qualité des services, il n'y a pas de différence entre secteur public et secteur privé. Il y a une autorité qui a été mise en place qui a comme mission de veiller à ce que le droit à la santé soit réalisé par tous, qu'on soit béninois ou non béninois, il suffit de résider sur le territoire, et se faire cela par l'amélioration continue de la qualité des soins. Et à ce titre, il y a deux axes importants qui ont été mis en place, celui de la certification des établissements est celui de l'accréditation des professionnels. La certification de l'établissement permet que le cadre dans lequel les professionnels vont exercer leurs compétences, qu'ils soient publics ou privés, que ce cadre-là réponde à des critères. Et cette certification n'a rien à voir avec la certification ISO, puisqu'elle va s'occuper d'un plateau médico-technique, elle va s'occuper de tel ou tel service. Et tout l'hôpital, tout l'établissement doit être certifié. L'accréditation, au contraire, elle va voir comment un professionnel, dans l'exercice de son métier, a amélioré ses connaissances, a amélioré ses compétences, a amélioré son savoir-être dans la relation avec les malades, et enfin, comment il fait pour prendre soin de lui-même. Parce qu'au-delà du malade, il est important de s'occuper de la qualité de vie du professionnel. Et là, on va l'indexer aussi, aller voir si ce professionnel, en dehors de son cadre professionnel, a des activités qui lui permettent de garder une bonne santé mentale, une bonne santé physique pour être opérant.
Okay, thank you very much. Quite impressive. And I'm going to build on what you have just said now. So when you contract with the private sector, 3 dimensions are important. You have articulated the quality dimension in terms of empanelment and accreditation. There's also how providers are paid. We've not heard so much about that. It would have been nice to have had, the Ghana DRG's, Nigeria Pays, capitation and fee for service. How has that experience been? And to say, look, public sector and private sector in certain places, they're paid the same, even when the salaries of the government workers are covered by government, and yet the tariffs are the same. But one issue that is perhaps a bit contentious is the benefits package. Look, on the subcontinent, you have what we call a triple burden of disease. There's communicable, there's non-communicable, and you also have severe emergencies. And it's really becoming hard to really have an actuarially fairly priced benefit package. And one of the things that a country like Nigeria has done is to, at the moment, take out financing, public financing for cancer care under what it calls the Catastrophic Health Fund or the Cancer Health Fund. Dr. Uche, you are directly involved in the management of that particular public financed fund for catastrophic care. What has the experience been?
Thank you so much. Good afternoon, everyone. Yeah. So in Nigeria, we have what we call Cancer Health Fund, and it came up as a necessity, and as a matter of fact, was championed by the Health Care Federation of Nigeria. And it came because we looked at the cancer care in our country, and looked at the mortality and the morbidity rate. And we were wondering what was the problem. Was it because of access, or was it because we have a different kind of variants of disease? And we found out that most patients are not able to finance cancer care, which is, I think, is what is obtainable in other African countries. So based on advocacy by the private sector, mainly, the government put aside funds to help indigent patients to get access to cancer care. And so far, the fund is being implemented mainly by the government funds, so we are hoping that the private sector will also contribute. And I'm sure they're also waiting for how that will be managed. And I can say that to an extent, it's been managed in a way that conforms with government policies. But I can say without fear that if you ask me whether I'm impressed, I will say I am not. Having been directly involved for at least close to 3 years now, I'm not impressed because of certain regulations that control that fund. So I think it should be removed out of that control so that it can achieve the main objective of purchasing care in an affordable manner that will involve many more patients and many more cancer areas. I understand that when it was conceptualized, it was mainly for 3 commonest cancers in the country: breast, prostate, and cervical cancers, which actually, if we're able to address those 3 cancers, we must have addressed over 50% of our cancer burden in the country. So I'm sure that was the reason for that. But then there are some other cancers that have more mortality, especially in children, that are actually preventable and can be cured, that are not covered. So that fund should be liberalized to include more cancer areas. And then when it was being implemented, it was being piloted in 6 hospitals, which were designated as centers of excellence. But unfortunately, because of a lack of certain kind of services in those hospitals, some patients are still not able to access those care in those hospitals. And that is where I think the private sector needs to also come into play, because if the private sector can place certain services that are lacking in those hospitals, that fund can be used to purchase that service in those hospitals. Okay, so, and going forward, we are now having discussions with the National Health Insurance Agency of the country to integrate this service into the health insurance. That way, it is going to be cheaper and then made more available to the citizens.
Okay.
So I think that's what we are.
Thank you very much. Couple of things from your intervention, which again, I would want the federations here to begin to pay close attention to. Defining the benefit package is something that must be developed collectively. The DG of Nigeria Health Insurance mentioned that there's a process to develop a health technology assessment unit. Is the private sector involved? You articulated perhaps there's a value to include childhood cancers. You know, what sort of process did the country go through to arrive at those 3 common cancers? So beyond some of the common things that we speak about at conferences like this, we probably need to begin to set up a specialized unit within the federations, employ health system strengthening specialists or health economists to help us also engage with government. You mentioned public financial management rules, which constrains the kind of purchasing that we have been talking here. What are those? How can we help? Perhaps these are some of the things we might want to consider in the communique. Also, the supply side availability and readiness. Must we only buy from the public sector? Do we have private providers who are able to provide such a service? Dr. Ben, Nigeria, perhaps in the subcontinent, is a country that has a federal political structure, which brings on its own a different set of challenges. Ghana and several other countries run mostly a unitary system, so to speak. But Delta State, where you work and lead the efforts there, is pretty much a country on its own. So 2 things for you. First, what is the relationship with the national level operators? And second, how are you able to advance reforms within your state?
Thank you very much. Delta State is a subnational region in Nigeria. In the southern part is the Niger Delta region, is one of the states. Over the years, there was a national health insurance scheme, and at the time, there was a plan to decentralize, where every state sets up its own health insurance scheme, but still relating with the national health insurance scheme. And that's what brought about the Delta State Contributory Health Scheme, which I happen to be the pioneer director general. And the concept is to mobilize the local resources, the local environment tendencies, and also ensure quality access to healthcare services for all residents of Delta State, irrespective of their socioeconomic status or geographical location. And at the onset, we did a lot of planning and all, and one thing was very obvious. Without the private sector, we will not be able to achieve the last mile of the expected outcomes. And that was how we decided to, first of all, engage with the NHIS, where NHIS sits on the board of the State Health Insurance Scheme. We have a template for correlation and interaction, and there are several feedbacks. In fact, at the initial onset, the idea was to have a unified ICT system where everybody's registration benefit package correlate. But because of the situation where the healthcare system is kind of independent between the states and the federal government, we had to find ways of interaction. The key point is the fact that we had the leverage to be innovative and be disruptive to be able to achieve our outcomes. And we started by being very deliberate in our engagement with both the public sector and the private sector. So our health insurance scheme operated from an independent body that looks at the public sector as one entity and the private sector as another entity, but a deliberate attempt to ensure that there's a correlation, a convergence of capacity, convergence of ideas, and convergence of the expected outcome so that we work together as one. And that was how I got engaged to the Healthcare Federation of Nigeria, within GIDE supporting us and the various other components of it. And we went about our outcome in a very clear pathway. First of all, we're very deliberate on what we wanted to achieve. So we had our early onset meetings, we set out the standards, we developed the framework together. So there was that constant, conclusive engagement, clearly spelled out. In that way, trust was built, transparency was obvious, and then the fact that we had knowledge of the fact that there were going to be challenges, we developed strategies to manage those challenges as they come, but ensuring that we combine our capacity on the basis of that you have your part, I have my part, we have to understand each other, but not deviating from the fact that there are these public sector nuances that we must also comply with. And that helped us achieve most of what we're going to do. One other very critical component that was quite important is the fact that there was a political will engagement from the onset. Political will engagement at the state level and at the federal level. At the state level, we met with the chief executive officer, explained the dynamics, and Njide was there. We went, explained, and he gave the go-ahead. But we also ensured that that political will was nurtured through the course of the program, through update reports, ensuring transparency and accountability, and also delivering the outcomes that were expected because a positive potentiation situation. So as you're achieving, you're getting more. We also ensured that we got the NHIS as part of the engagement process because you also need the political will of the headship of the NHIS. We tried to create several other innovative ways to ensure we achieve those outcomes. They were a bit difficult, but at the end of the day, through the relationship with the private sector and the Healthcare Federation of Nigeria, we'll be able to achieve it. But the last point is this, something I noticed because I'm a private sector person that got into public sector work. One very critical thing I will advise is this. From my experience and what I've seen, I hear Olumide ask Claire, is the private sector on the table? And Claire said yes. The question is, what table are you in? If you go to a function, you have a table in the dining room, close to the kitchen. You have a table in the parlor. You have a table in the compound. You have a table outside. Everybody is on a table eating. But the question is this, where are you? The private sector right now had been sitting outside of the compound in the outside canopy. They are currently in the compound, but they are not yet at the dining table. Because if you sit outside, what you get is what is able to pass through the door or the window. But when you're sitting right there, you are close to the source. So I expect that right now, the private sector should sit right in the middle of it, be fully engaged. It's always easy to say, oh, the public sector is not a very safe and convenient place to go. No, you have to take the hit. You have to go in there and make the change internally. Thank you very much.
No one could have said it better. Real life example of what he has just said. Where are the conversations in terms of tariffs? How much are you paying me? How much are you paying the public sector? Why should you not give me a differentiated payment? Okay, how are we going to institutionalize provider payment reviews on an annual basis? Inflation is currently 22%. This means you have to commission work in the background, in the universities, so that you are at the table with facts. Ladies and gentlemen, I have an opportunity. My panelists, they've done very well. A round of applause for them. But so we've been able to save some time. So that means I'm happy to take 5 30-second questions. But the first opportunity will go to Ricardo. So you are my number one, Ricardo. You're going to tell me how federations also, like using the example of Benin, how they can also become sustainable. It's a powerful experience to share. So that's, Ricardo is 1. I need 4 more. Show of hands. 2. Shegun. 3. 4. 5. Good. All right. Ricardo, we'll start with you. If you guys do a good job, we might even go for another round. All right, Ricardo, where's the microphone, please? Microphone. So, Ricardo, just very quickly, just in 30 seconds or less.
Cool. OK, merci beaucoup. Je vais parler français. Je voudrais simplement dire qu'en termes de durabilité des plateformes et aussi de la Fédération ouest-africaine, quand je commence par la Fédération ouest-africaine, si les membres, les pays ne sont pas capables pour s'asseoir sur la meilleure table, comme l'a dit le confrère tout à l'heure, la fédération n'ira nulle part. De la même façon, au niveau pays, si les membres des fédérations nationales ne sont pas capables de s'asseoir sur la bonne table, c'est que la fédération nationale n'ira nulle part. Ça veut dire quoi? Que si nous avons $1 d'un bailleur où nous créons des ressources domestiques internes, nous devons penser à comment chaque niveau de notre fédération prenne part un peu à ce $1 pour avancer leur maturité, pour être capable de rester sur la meilleure table. Dernier point, nous sommes tout le temps en train de courir pour dire bailleur, gouvernement, central, mais nous oublions les gouvernements, la gouvernance décentralisée. Je veux dire les maires, les préfets pour certains pays, les gouverneurs pour d'autres pays, toutes ces autorités décentralisées. Ils gèrent aussi, quand c'est bien organisé, ils gèrent des budgets, ils gèrent des revenus. Comment le secteur privé collabore avec un gouverneur, collabore avec une mairie, un maire, pour mobiliser des ressources, mais aussi renforce le leadership, renforce le partenariat privé au niveau décentralisé, et c'est tout ça qui contribuerait effectivement à des financements durables pour les plateformes. Merci.
Thank you, Ricardo. Number 2. Okay, please try and keep it short. Not as long as Ricardo.
Okay, I'll try and do the 30 seconds. Dr. Shegun Ebitomi. I'm a medical software entrepreneur. I run a group of hospitals in Lagos, and right now working on a project to aggregate 60 hospitals in Nigeria on the road to 100, and then eventually 10,000 health centers run with artificial intelligence. Now, we've been talking the last 2 days about the role of the private sector, and I'm going to propose a simple software protocol to solve that problem. The role of the private sector is simple. They are the one that will create this trust that we are always talking about, because they house the quality service, either in the primary care centers, secondary care centers, or in the tertiary care. And how do we empower the private sector to deliver this trust? First, as public sector, as government, get out of service delivery. Stop building hospitals. Stop paying salaries. Stop buying equipment. Rather, buy service. This year, the budget for Nigeria was about 1.4 trillion.
Okay, so is that a program? Is it coded already? Round of applause for Shegun. Number 3. Number 3. We need to go. Number 3. 3. Here you go. 3 is here. 3, 4. Okay. Go ahead.
Thanks. Moi, je voulais demander qu'on fasse un banc à notre président Lucien Dossouk-Better parce que c'est l'exemple de l'engagement qui nous permet d'être à la bonne table. Et aujourd'hui, il préside l'autorité nationale béninoise de régulation du secteur de la santé après être passé par, je dirais, un engagement. Merci. Et ce que je voulais dire à ce propos, c'est que le cadre de ce débat pour aller vers une couverture santé universelle et la mobilisation que nous voulons faire au niveau local pour avoir les ressources pour le financer, le rôle du secteur privé sera aussi de s'engager pour créer des solutions. On a des exemples. Moi, je suis pharmacien. Et le Maghreb, l'Algérie, dont j'ai vu un peu l'expérience, quand ils ont créé l'assurance maladie universelle, mobilisé des ressources locales pour pouvoir financer cette assurance, en face, il y a eu une motivation à la création des industries locales pour permettre que les ressources mobilisées ne s'évaporent, n'aillent à nouveau à l'extérieur. Et je pense que c'est un créneau dans lequel les acteurs du privé que nous sommes devront nous inscrire pour prendre au rebond, en tout cas, tout ce qui se fait en termes de mobilisation de ressources. Et il y a aussi la création aussi des technologies et des offres de santé efficaces dans le secteur privé pour pouvoir assurer des soins de qualité à nos populations. Merci.
Bonjour, Charles Boguifo, je suis le premier vice-président de la Fédération, l'instance de coordination du Fonds mondial et puis ancien président du Conseil national de l'Ordre des pharmaciens. Alors, moi, j'ai vachement apprécié l'intervention du Bénin et je voulais juste qu'on puisse coordonner parce que je crois qu'il y a un aspect qui reste primordial et important, c'est justement la qualité de soins que doit pouvoir bénéficier, je dirais, le patient. Cette qualité soit la même aussi bien dans le secteur public que dans le secteur privé. Et donc, cet élément est primordial parce que lorsqu'on regarde la Côte d'Ivoire, on parle de solidarité, mais justement, ceux qui cotisent n'iront pas dans le secteur public parce qu'ils estiment que la qualité des soins n'y est pas. Ils resteront dans le secteur privé et donc ils cotiseront sans pouvoir bénéficier. Or, pour qu'on puisse aller d'abord pour parler par rapport à une tarification qui puisse être fonction justement des salaires, il faut qu'ils puissent aller où ils le veulent et bénéficier des mêmes prestations. Et pour parler de l'action du secteur privé, moi je dis venir à la table, c'est bien au-delà. Le secteur privé doit pouvoir être la structure qui puisse apporter également au gouvernement les réalités de l'inexistence sur le terrain et ce que le secteur privé peut apporter en termes de qualité. Et donc, c'est pour ça que, pour rappeler, la qualité du secteur privé doit être toujours au plus haut niveau pour que les gouvernants puissent nous écouter avec déférence. Et quand on dit nous écouter, on doit pouvoir participer même au plan stratégique concernant le secteur de la santé. Il ne s'agit pas qu'ils fassent leur plan et que nous, on vient pouvoir voir dans quelle mesure y participer. Il faut qu'on soit dans la composition dès le départ. Et ça, je pense que lorsqu'on apporte des données qualitatives, et ça, c'est quelque chose qui nous manque dans le secteur privé, c'est apporter des données fiables. Donc, il faut qu'on y pense au niveau des différentes fédérations, qu'on soit capable de mobiliser des données dans le domaine sanitaire pour nous permettre d'être crédibles, aussi bien vis-à-vis de nos gouvernants, mais aussi vis-à-vis des bailleurs de fonds.
Absolutely. Thank you. Okay. Sorry, sir. You were not part of my 5. Were you? Okay. So just to be sure that, do we still have any other person who wants to make a comment? Let me just check. Show of hands. Any other person? 1, 2, and that will be it. Go ahead, sir. Then you and Chidoke. Please keep it short.
Voilà, merci. Moi, c'est Omar Sy, secrétaire général de l'Alliance du secteur privé de la santé du Sénégal. Bon, moi, depuis que le congrès a démarré, je vois que beaucoup de présentations sont toujours au niveau stratégique. Le Sénégal a mis en place une alliance du secteur privé de la santé en 2014. Et en 2016, nous avons signé un mémorandum, l'alliance a signé un mémorandum d'entente avec le ministère de la Santé et avec des engagements de chaque partie. Le ministère, pour ces engagements, je peux dire que ça a été réalisé peut-être à 90%. Nous disposons d'une cartographie, nous sommes qui nous sommes, combien nous sommes, quels services nous offrons aux populations, dans quelle région nous sommes situés, sur les 14 régions du Sénégal. 3154 structures privées de santé, 1800 pharmacies, 1225 structures privées de soins, 6 fois les structures privées, publiques. Ça, c'est pas comme le Togo. Hier, j'ai entendu la présentation. Il y a moins de structures privées au Togo que de publiques. Nous sommes 6 fois les structures publiques. Donc, toutes les planifications sanitaires qui ont été faites avant 2014, où l'alliance a été mise en place, sont incomplètes. Parce que les structures privées sont plus nombreuses que les structures publiques. Maintenant, il y a eu le mémorandum d'entente et tout. Nous sommes maintenant au niveau opérationnel. Le niveau opérationnel, il faut que les acteurs du secteur privé de la santé soient engagés. Comment les engager? Plusieurs scénarios ont été mis en place. Et le ministère de la Santé, avec l'appui de l'USAID, avait mis un projet de 2018 à 2021. Et ce projet a permis de financer seulement les activités du secteur privé de la santé. Et les leçons apprises par rapport à ce projet, c'est qu'aujourd'hui, afin que le secteur privé puisse jouer sa partition comme un des pieds, les deux pieds là du système de santé, l'un est public, l'autre est privé, il faudrait qu'il y ait des engagements, que le secteur privé soit engagé. Comment l'engager? C'est des MOU, des conventions. Conventions entre structures privées de santé et districts pour améliorer le cadre de collaboration, intégrer les structures privées dans le district, n'est-ce pas, afin qu'ils puissent participer aux réunions de coordination, aux activités de formation.
Very well made.
Non, je n'ai pas fini. Il faut continuer parce que depuis le démarrage, je n'ai pas encore parlé. Il faut que je parle.
Go ahead.
Donc, il y a l'amélioration du cadre de collaboration, la disponibilité des données sanitaires, il faut l'engagement avec la CMI. Pourquoi avec la CMI? Nous, au Sénégal, nous sommes dans une phase où des tarifs préférentiels vont être proposés par le secteur privé au bénéfice des 6 millions de Sénégalais qui n'ont pas de couverture sanitaire, maladie universelle. Ils n'ont pas d'assurance maladie, donc il faudrait qu'on les prenne en charge. Comment? Entre le tarif proposé au centre de santé et à la clinique, et le tarif proposé à la clinique, qu'un tarif intermédiaire, préférentiel, puis où les populations pourront accéder à des soins de qualité à moindre coût. Et ça, une expérience avec SOPS Plus a été développée et aujourd'hui, c'est cela. Nous sommes dans l'amélioration de la qualité. Il n'est pas possible dans un pays que les méthodes, les normes et protocoles utilisés au niveau du public ne soient pas utilisés au niveau du privé. Il faut l'amélioration donc de la qualité des prestations du secteur privé. Et aujourd'hui, il y a le coaching sur il y a beaucoup de choses qui sont faites pour afin de...
Thank you very much.
Merci. Je n'ai pas fini, mais bon, je m'arrête.
Thank you. But, no. By the way, you make extremely important points. And to be honest, Madam Chair and leadership, the kind of points you made, sir, I think deserves a whole session on its own. To me, those will be some of the key objectives of meetings like this. The second person is here. We'll come to you. You, Dr. Wilson, and Dr. Chijoke. Go ahead. Yes. But please keep it short.
Yeah. Moi, c'est Luc Diogbenou. Je suis toujours universitaire, donc c'est un troisième larron. J'aime le dire dans le combat, dans ce duel, et secteur privé et gouvernement. Et c'est ça que je voulais proposer, parce que tout à l'heure, Dr. Dessou-Bédé disait il faudrait que nous comprenions les défis de la même manière. Et je pense que dans un dialogue, si chacun amène avec ses ressentiments, ils ne vont pas se comprendre. Donc, un troisième larron pourrait se trouver au niveau de chaque pays, qui sont nous les universitaires et quelques autres parties prenantes, pour faire le troisième larron, pour essayer de faire comprendre les enjeux par les deux parties. Merci, je propose cela pour qu'on puisse avancer.
Thank you very much. Dr. Wilson, do you have any comment on the Ghana DRG or provider payment? Any comment from the Ghana team? Because we haven't heard anyone say anything about provider payments. apart from Senegal, please.
So
then,
Ghana,
then we'll go to Dr. Chijoke, please.
So
very quickly, just very quickly.
Yeah, Ghana has tried to experiment with the three mechanisms. So fee for service, DRGs, and capitation. I think the beautiful thing that we learned from the beginning was that you have to pay different provider types differently. So in Ghana, we have 3 levels of payment. The least is the public sector. The public sector is paid least, followed by what we call private non-profit. And then the highest tariff goes to the private for-profit. And that's because the midsection, which is the private non-profit, the government also subsidizes equipment and all that. So you have to tier.
Thank you very much.
Mechanism.
Again, those are things I think we should be able to learn from. Chijoke, last word.
Yeah, thank you very much, the moderator. You did a wonderful
minute.
job. I have a question for the minister.
Keep it short.
Yeah, from the minister from Liberia. You talked about healthcare promotion. I publish a magazine, Afri Health magazine. I want you to tell us in Liberia, how do you go about it? Because in Nigeria, I'm a doctor. At the time, I was seeing a lot of patients, and when they come, I find myself taking a long time to educate them. So we started something they called Afri Health, where we organize healthcare events and also publish magazines to educate people. Because if we educate this, if we educate people, it makes the work easier for us as doctors. So tell us, you talked about it. So in Liberia, how do you go about promoting healthcare
Honorable Minister,
in Liberia? Because
I can answer that for you.
Because in Nigeria, we have already started.
That's fine, Chijoke. So perhaps you want to have Afri Health organize an exhibition in Liberia. Thank you very much. Round of applause for him. All right, Dr. Uche, we'll start with you. We'll start with you, Dr. Uche. Sorry, who? If you're going to keep it 30 seconds, otherwise I'll have to unfortunately cut you off. People got to go pray, all right? So 30 seconds.
Oui,
go on.
Oui, 30 secondes. On se rend compte que le défi ici, c'est comment engager le dialogue avec le secteur public. Là, je parle du point de vue, puisque j'ai intervenu en son temps en tant que partenaire technique financier, et maintenant, j'appuie la partie nationale. Mais je me rends compte que le gros problème, c'est comment engager le dialogue. Je pense que ça pourrait être un des objectifs clés de la plateforme. Comment former nos dirigeants au niveau de la plateforme pour engager efficacement le dialogue avec le secteur privé, avec le secteur public. Je pense que c'est à cela que nous, au niveau du secteur privé, on doit travailler. Puisque nous voulons être à la table, à la bonne table, mais comment on va à cette bonne table? Merci.
You know what? I don't want that question to be lost. Claire, can you just use your 1 minute to close to answer specifically that question? Leadership for federations so that we can be on the right table.
Thank you, Olumide, and thank you to our last speaker, because you hit the point. When I saw him raise his hand, I knew it was a question we needed to answer. This is specifically one of the reasons why we have the Journey to Sustainability program, funded by our partners USAID, which is to be able to build each of the various platforms to mature organizations. You see that the various countries, 9 federations, are at different levels. The more mature ones know exactly how to engage government. They're not just at the table, but they're writing the menu of the food they're going to eat. So let me move it forward. Some have to get to the table, some need to get to the high table, some need to write the menu. What are we going to discuss at this meeting? And this is the reason why we're going to bring everybody to different levels. The whole idea of sustainability is to be self-sufficient, but to be recognized as a formidable body that you cannot make any decisions, you cannot formulate policies, you cannot write plans without the level of the federation there. And this is what we've been able to do and we're achieving. So capacity building of the federations is critical and pivotal to what we're all talking about here.
Thank you very much.
Thank you.
Dr. Uche. Last word.
Okay, thank you so much, everyone. I think the way to go from all have been said is collaboration, collaboration, collaboration. And one advice I want to give to everyone is the example of HFN in Nigeria. where they actually put the government on toes to ensure that even when we try to derail from operational plans, they still try to draw us back. So that means being at the right table is also being perseverant, making sure that you persevere even when the thing seems not to be in your favor, but to make sure that everybody is put on his toes to do the right things. Thank you.
Thank you very much. Dr. Lucien.
Oui, juste pour dire que le secteur privé, dans le dialogue avec le public, on a tendance à chercher l'erreur chez l'autre. Mais il faut qu'on prenne conscience de ce que nous ne faisons pas, ou ce que nous ne faisons pas assez, ou ce que nous faisons mal pour rendre ce dialogue difficile ou impossible. Nous avons les clés, secteur privé. Au Bénin, 52% de l'offre est assurée par le secteur privé. Donc, autant d'éléments qu'il faut documenter pour savoir combien ils pèsent. Une fois qu'on sait combien vous pesez, ben c'est l'autre qui vous dit « viens à la table ». Et là, vous arrivez avec des documents, avec des propositions claires. Mais pas aller pour revendiquer, mais avec des offres. Merci. Une particularité au Bénin quand même, c'est que c'est le ministère de la Santé qui s'occupe de l'offre de services. Alors qu'au contraire, l'achat est assuré par le ministère des Affaires sociales. Pourquoi? Parce que l'assurance maladie universelle a démarré avec les pauvres extrêmes et c'est l'État qui finance les primes des pauvres extrêmes. Comme il finance, il veut savoir comment l'argent est géré. Donc il garde la main sur la gestion de l'argent à travers le ministère des Affaires sociales. Merci.
Thank you so much. I think just for people who probably missed your point, in fact, for countries who have made progress, Gabon, Egypt, actually you have ministries of social protection, sometimes Ministry of Finance, actually, or even in India, where Modicare is managed as a social protection program. And perhaps when I mentioned we should be deliberate, we should be intentional, maybe those are the kind of conversations we need to push our public counterparts to do. Second point about you, sir, it is when we keep doing things like this, now that you're in your big office, that means you won't forget the private sector. Okay. Dr. Ben, last word.
My last word is that we need to also realize that too much talk doesn't lead anywhere. We should have talk time, action time. A conference like this should actually have morning session for talk, afternoon session for a team to develop an action plan that is implementable. Because until we have a deliberate, focused action plan where there's a convergence of the public sector capacity and the private sector, public sector capacity and the private sector capacity, focused on the expected outcomes, we will not achieve universal health coverage. Thank you.
Honorable Minister Tulay, you're my last guest, and you have the last word.
Thank you once again. So I'd like to conclude by thanking the organizers. And like I said in my slide points, some of the missing things I see from this meeting are the incomplete stakeholders. I do not see, at least on the program, those with chronic disease conditions. If you're having a dialogue on healthcare provision, I think those who are the end users need to be incorporated. I do not see local leadership, community leadership. You need to include them because they are the one who will provide safety and security. But hey, let me go back one more second to acknowledge that the private sector is doing a whole lot. Don't get me wrong when I say that you have deliberately omitted two key components. I'm saying and encouraging you to expand in those areas because when you have preventions, when you have awareness, you will have lesser cases of hospitalization and thereby leading to a greater health outcome for smaller money. Remember, there will always be scarcity of resources. Now, the final word I want to say, in spite of all of the glamorous things that you have said, let's look at the private sector as an entrepreneurial investment. and the level of return is dependent on the capital investment. Many of these private sectors do not meet the financial status to provide the quality of health services that we want, thereby creating other health disasters. Like the case of polypharmacy, you visit a private facility in many parts of Africa, they will prescribe 10 different medications for a simple condition that requires just 1 or 2 medications. Why? Because they want to ensure sustainability. So, I mean, it's a good thing you continue to debate and dialogue, but you also have to ensure that the quality. Now, finally, I'd like to acknowledge what has been done thus far by the Liberian Health Federation. They've done well.
Please, round of applause for Liberian Health Federation.
Even though my federation cheerleader and I, we are almost at fighting one another because I'm saying quality, and she's saying we will get there. I said, well, you are not going to get there until you can ensure that there is quality in the work that you do. I tell you no lie, when I see some of the private healthcare providers in my country, you wouldn't want to visit the place. And they are the private healthcare providers. But she and the team have been doing some very good job and what have you. And USAID also needs to be acknowledged. Through USAID funding, we've been able to develop the private sector engagement strategy. We now have our own health financing strategy as well as a draft bill for national insurance. Now, my final conclusion is to differ with my moderator honorably in a very direct and polite word that in order for us to ensure an effective healthcare system, everybody must contribute. Now, the tendency for national government to send an allocation to be managed for healthcare provision leaves a good room for mismanagement and misdirection. Now, let me stop here so that I don't have to go beyond this point to, have it. But thank you so much for inviting me and allowing me to share my Liberian experience. Thank you.
Thank you very much, Honorable Minister. Ladies and gentlemen, it's been an intense 1 hour or so, just exactly what we expected to have. For me, my key takeaways are simple. Money is tight. The fiscal space would always be constrained. In fact, it's even getting worse. And the minister says, you know what? Prevention is better than cure. So in other words, we need to be part of that benefit package, which also emphasizes preventive strategies. The second thing is that UHC is an extremely political process. It's not about the big grammar that we're talking about here. How do you negotiate that process? And I think we've heard that from the case of Nigeria with its intense federalism dilemma. A third point for me, the gentleman here, how is healthcare telling its story? How is it associated with economic growth? A third of economic growth from the East Asian countries came as a result of fast-tracking their demographic transition. And that demographic transition was as a result of reduction in mortality, reduction in fertility. Actions that happened in the health sector. How do we quantify that to the political leaders to say, hey, look, this is intricately tied to your economy if you prioritize healthcare. Another one is that, look, you know what? We are certainly not all the same. And that's one of my key takeaways from the gentleman in Senegal. You know what? You got to do a private sector health assessment. You need to have your UHC strategy. Do you actually need a private sector? Can they contribute to your strategy? Those are hard discussions to have. Because Nigeria is doing it does not mean you should do it. And it's only when you have done that assessment, when you have a strategy and policy statement, that's then where you know. And last point, sir, it's always good to disagree. You know what? I know for a fact that across all our countries, we have a high level of informality. I know for a fact that across all our countries, we have a high level of poverty. I know for a fact that the transaction cost of trying to identify and collect contributions will be an almost impossible task. From where I sit, I do not know any country, that has been able to successfully do this contributory approach that we're talking about. In fact, for the countries that are far advanced on UHC, they are moving back to budget transfers. Ladies and gentlemen, it's always good to disagree. Please, a round of applause for my distinguished panelists.